Mr. Chairman, dear colleagues, first of all, I would like to thank the CRI organization for inviting me to this meeting once again, and to discuss with you, to address the problem of scarring of the athletic heart. So with the growing availability of cardiac MRI studies, the concept, the definition of structural normal heart has changed. Thanks to gadolinium-enhanced testing, now we are able to identify, to detect scar myocardial lesions that fall under the resolution power of echocardiography. This is very important because echocardiogram is traditionally considered the test discriminating between a structurally normal and a structurally abnormal heart in the clinical practice, particularly in the setting of screening athletes. So it's a surprise for us to understand that a sizable proportion of overtrained athletes show a heart remodeling that include myocardial scar. These scars have been described also this morning, are characteristically localized in the septum, are focal and localized in the septum, especially at the junction between the left ventricle and the right ventricle. So in terms of pathophysiology, of the etiology of these myocardial lesions, these patterns with this peculiar localization resembles that described in patients with the pulmonary hypertension, as said by the authors of this important paper, in whom increased interventricular wall stress caused by right ventricular pressure overload may cause such lesion. The significant increase of pulmonary pressure demonstrated in training athletes during intense exercise suggests a similar physiologic stress, a similar pathophysiology. So we don't know exactly the clinical meaning of these lesions and the outcome of athletes showing this myocardial lesion only visible through MRI. So more studies are needed in order to clarify this point. So today I would like to focus your attention on two other kinds of myocardial scar that can be detected in young competitive athletes and can be associated with the risk of life-threatening ventricular arrhythmias. These scars are, like the previous one, echocardiographically silent. This is the concept. In other words, the echocardiogram may misdetect this kind of myocardial lesion. So it's important to know the presence, the possibility to detect this myocardial lesion at risk. So an echocardiographically scar myocardial lesion may underlie, in some cases, idiopathic right ventricular outflow tract tachycardia. This is the most common ventricular arrhythmias in the population, and is morphologically characterized by a left bundle branch block morphology with inferior axis that denote the origin from the anterosuperior part of the right ventricle, that means the right ventricular outflow tract. Usually these arrhythmia can occur as isolated premotor ventricular beats or repetitive monomorphic ventricular tachycardia or sustained paroxysmal ventricular tachycardia. But usually, in more than 90% of cases, is non-familiar and is benign. So it is not associated with an increased risk to die suddenly. Exceptionally, as demonstrated post-mortem in this particular case, but in other cases reported in the literature, this condition actually is associated, may induce sudden death. In this particular sudden death victim, we were able to demonstrate a segmental right ventricular lesion. You can see this is a part of the right ventricular flow tract. This is a pulmonary artery, the pulmonary valve, this particular part of the right ventricular flow tract is translucent. That means that the right ventricle is very thin, is lost and substituted by fibrofatty replacement, by fibrofatty tissue, as you can appreciate in this histological section of the same region. So a segmental right ventricular scar may underlie this kind of arrhythmia that usually idiopathic and benign. In order to evaluate the presence of this echocardiographically silent myocardial scar in patients, as you will see, most of them were athletes undergoing for catheter ablation because of the diagnosis of right ventricular flow tachycardia. We used the technique of right ventricular voltage mapping. That means to record in the setting, in the cavity of the right ventricle, endocardially, the electrical activity. When the electrical activity is reduced or lost, this means that the myocardium is replaced by fibrous tissue or fibrofatty tissue by a scar. So usually the scar tissue is represented in red, while the preserved myocardial tissue is coded in purple. So we assessed whether voltage mapping of the right ventricle, because of its ability to detect electroanatomic scar corresponding to areas of right ventricular fibrofatty replacement, can differentiate between two conditions: idiopathic right ventricular flow tract from arrhythmogenic right ventricular cardiomyopathy. We studied 27 consecutive patients. The majority were 15 males and 12 females with the right ventricular flow tract tachycardia. This is important. They had no echo nor MRI evidence of right ventricular dilatation dysfunction, no wall motion abnormality. So the diagnosis was idiopathic right ventricular flow tract tachycardia, the diagnosis at the time of admission for catheter ablation. There was no left ventricular involvement, and they had a follow-up of at least 6 months. So in the majority of these patients with right ventricular flow tract tachycardia, we actually found that the voltage mapping was normal. In other words, the myocardium was preserved. There was no evidence of scar. You can see a representative example of a normal voltage mapping. The voltages, the amplitude of the electrograms on the cardiac electrogram were preserved. So the right ventricle, the geometry of the right ventricle reconstructed according to the electrophysiological information showed a normal myocardium. You can see here the corresponding biopsy that is normal biopsy, and this is the arrhythmia, the typical right ventricular flow tract tachycardia with left bundle branch block morphology and inferior axis. In this particular case, we deal with the true idiopathic right ventricular outflow tract tachycardia. Instead, in 25% of this particular cohort was a selected population of individuals with arrhythmias, we found some abnormality of the voltage mapping. You can see an example of a segmental scar in the right ventricular flow tract. This is the right ventricle. This is the area, red colored. And you can see the biopsy that correlate perfectly in terms of myocardial loss and fibrofatty replacement. And you can see here the corresponding clinical arrhythmia. So we compare patients with or without an abnormal voltage mapping in order to identify the clinical predictors of the scar, because of course we are not able to study all patients with right ventricular outflow tract arrhythmias with endocardial voltage mapping. And you can see here that there were no differences in terms of clinical parameters between those with or without an abnormal voltage mapping. You can see here that a sizable proportion of this cohort were competitive athletes presenting with right ventricular flow tachycardia and requiring a differential diagnosis with a cardiomyopathy. Instead, you can see here an important finding that there was a significant difference in terms of QRS duration in the leads exploring the right ventricle. In other words, with the presence of a localized, non-specific intraventricular conduction defect, and the presence of late potential on signal level ECG. All findings suggesting the presence of intraventricular conduction defect. Again, you can see here that there was a significantly association with induction of the tachycardia at programmed ventricular stimulation is here. In other words, you can see that programmed ventricular stimulation was able to induce a ventricular tachycardia significantly more often in those with an abnormal mapping. That means that, of course, in this particular case, the ventricular tachycardia recognizes a reentrant mechanism around the scar. So there was no difference in terms of success of catheter ablation between those without and with an abnormal voltage mapping. This latter population required a more extensive catheter ablation sites in the right ventricular flow tract, often encircling the scar, the segmental scar in the right ventricular flow tract. But what is important is that we found that patients with a scar, with demonstrated scar, actually had a worse outcome. The majority of them required an ICD therapy because of life-threatening ventricular arrhythmias that occurred during the follow-up. So in other words, this segmental scar has an important clinical meaning. Is associated with a worse prognosis when demonstrated. So these findings are consistent with those reported by Professor Buchel in the past, showing that in the athletes with arrhythmias, usually the majority of arrhythmias come from the right ventricle. In other words, show a left bundle branch block morphology. And what is important is that in this particular population of athletes with arrhythmias, the outcome is strongly related with the inducibility of the tachycardia at programmed ventricular stimulation. In other words, when the tachycardia is scar-related, is associated with a worse prognosis. This scar often may be undetectable by echocardiography, by the traditional imaging techniques for evaluating the right ventricle. So the echocardiographically silent right ventricular flow tract myocardial scar may underlie apparently idiopathic. That means with apparently normal heart, right ventricular flow tract ventricular arrhythmias in young people and athletes. The techniques is able to identify otherwise concealed right ventricular outflow tract and anatomic scar that correlate with the fibrofatty myocardial replacement at endomyocardial biopsy. So we have a validation of this finding, and inducibility at programmed ventricular stimulation. That means scar-related ventricular arrhythmias, and may predispose, most importantly, to sudden arrhythmic death. What about arrhythmias instead with the right bundle branch block morphology? That means an origin from the left ventricle. So we have new data about these arrhythmias and the potential underlying myocardial substrates. You can see an example of a sustained ventricular tachycardia with right bundle branch morphology and superior axis, suggesting an origin from the inferolateral apical wall of the left ventricle. So you can see here our results. Among roughly 700 athletes we studied because they presented ventricular arrhythmias. You can see here that in the majority of them actually had arrhythmias with the left bundle branch block morphology. That now we don't deal with them. So now we concentrate on those 115 with the right bundle branch block morphology, arrhythmias suggesting the origin from the left ventricle. So these athletes underwent second-level examination by echocardiography, that is the traditional test for discriminating between normal and abnormal heart. And you can see here that 8 of them actually had the clinical echo diagnosis of cardiomyopathy. But the majority of them actually showed a normal echo. So only part of them underwent further examination. Those with a family history, positive family history, those with repolarization of myelitis, or showing complex ventricular arrhythmias, that means couple non-sustained VT, and so on, or symptomatic for syncope. While the other 50% were diagnosed with idiopathic ventricular arrhythmias with a right bundle branch block morphology. So what about this subgroup undergoing further examination? This is a surprise. In 40% of them, we found late enhancement in the left ventricular wall. So the 22 athletes with this kind of scar, left ventricular scar, at the mean age of 35 years. Most of them were males, competitive athletes. 18% had a family history for premature sudden cardiac death, 18% cardiomyopathy. Personal history was often positive for palpitations, occasionally for syncope. And what about the ECG abnormalities underlying this kind of left ventricular scar? You can see here that we observed repolarization abnormalities in roughly 50% of them. Repolarization abnormalities localized in inferolateral leads exploring the inferolateral wall of the left ventricle. And another important finding was that we found in roughly 20% of them relatively low QRS voltages in the limb leads. In other words, the presence of scar replacing the myocardium is associated with the loss of voltages. Late potential, very importantly, was also demonstrated. Late potential were also demonstrated in roughly 50% of them. What about the echocardiographic findings? In the majority of these athletes, the echocardiogram showed just a left ventricular dilation that was consistent with the remodeling of the heart due to exercise, and not sure hypokinesia of the inferolateral wall just in 4 of 22. The right ventricle was normal. So this is the scar we observed in this subgroup of athletes. Is at the CMRR showed a left ventricular dilatation in terms of left ventricular involvement. Right ventricular wall motion abnormalities were demonstrated in only 23%. But what's important is that the left ventricular late enhancement, of course, was demonstrated in all these 22, was inferolateral in 82% and was epicardial mediomural in the majority. So, in other words, we deal with an epicardial scar in the left ventricle that is mostly localized in the inferolateral wall. This is important because this scar is not transmural. It's just epicardial. This explains why the echocardiogram is silent, misses this scar, because the scar to be evaluated, to be recognized by the echo, must be transmural, accounting for a wall motion abnormality. In the controls, we didn't observe, never observed late enhancement. So what about the follow-up? Because usually this kind of finding is dismissed as healed myocarditis. So benign healed myocarditis without clinical meaning. What about the clinical outcome of our athletes? So it's not so benign. Look, 6 of 22 actually had major cardiovascular events during the follow-up of roughly more than 2 years. 1 died suddenly due to ventricular fibrillation, 3 experienced appropriate ICD intervention on VF or VT, 1 experienced sustained ventricular tachycardia, and 1 experienced a cardioembolic stroke. So look at this athlete. It's not Morosini, it's another athlete. It's a Spanish athlete who experienced this cardiovascular event during a game years ago. It was a prolonged episode of syncope. But unlike Morosini, that is, the soccer Italian player dying suddenly, look, it's very similar, the action when he experienced this problem. So unlike Morosini recovered spontaneously, it was a prolonged episode of syncope and recovered spontaneously. So he had a prolonged syncopal episode, effort-related during a soccer game, the Spain National Championship, and he was a 27-year-old professional soccer player with no family history of sudden cardiac death cardiomyopathies, was previously asymptomatic. The ECG showed inferolateral reparation abnormalities. The echo was completely normal. In fact, these ECG abnormalities were initially interpreted as reparation abnormalities consistent with the channelopathy because there was no evidence of structural abnormalities. So this is the ECG. You can see here the reparation abnormalities in the lateral leads and inferior leads. This ECG was recorded late after, of course, the event. So this ECG. Look at the MRI. The contrast-enhanced MRI unmasked the presence of this epicardial scar in the inferolateral wall of the left ventricle and also involving the apical septum. We performed a cascade family screening that was negative in this particular case, but we found that molecular genetics, the presence of a gene mutation, the plakophilin gene, that is a gene, desmosomal gene encoding for proteins of the desmosomes, and is consistent with the genetic background of arrhythmogenic right ventricular cardiomyopathy. But in this particular case, there was no evidence of right ventricular involvement. It was an involvement localized to the left ventricle. It was selectively, exclusively involving the left ventricle, but was justified, explained by the presence of desmosomal gene mutation. So at that time, I was consultant of the Madrid team, and I advised to implant an ICD. He actually, of course, had an important cardiovascular event. So they first treated by beta blockers, and then they convinced them to implant an ICD. And I received an email a few months ago from the medical team of the Madrid, showing that after 32 months of follow-up, during a leisure time tennis game, because of course these athletes are former athletes, they perform some kind of sport activity. So during a tennis game, he experienced this kind of arrhythmia, this ventricular flutter that was recognized by the ICD and actually interrupted. So in other words, had a relapse of the life-threatening ventricular arrhythmias that could have been fatal in the absence of the ICD. So look at this other case. This was a 27-year-old professional cyclist. He has an industry of bicycle in Italy. It was a very important industry. So he was a testimonial of the industry, his own industry. So he had no family history of sudden cardiac death or cardiomyopathy, completely asymptomatic, but a ECG alter, and basal ECG and ECG alter, he showed preventricular beats with the right bundle branch block morphology. So you can appreciate that. This is important because it's extremely important to perform while examining, while evaluating athletes. It's important to perform a 12-lead alter monitoring. It's more important the morphology of the arrhythmias you record than the severity, the grading, coupled, triple, some sustainability. It's more important the morphology that denotes the origin of the arrhythmias and potentially the underlying cardiovascular subset. So he actually had a couple preventricular beats with the right bundle branch block morphology and superior axis. This is the ECG. Unfortunately, the ECG was unremarkable, with the exception of relatively low crest voltages if you consider that it was a competitive athlete, it was a trained athlete. And the echocardiogram was completely normal. So we should consider, according to the traditional concept of the normal structural heart, that this heart has idiopathic ventricular arrhythmias. Instead, he underwent an MRI because of the complex ventricular arrhythmias, and you can see here that the post-contrast sequences showed epicardial late Galeni enhancement in the basal inferolateral wall. We deal once again with an epicardial scar in the left ventricle that was segmental, was localized to the inferolateral basal wall, and unfortunately died suddenly during a cyclist game. And you can see here, for the first time, the correlation with the post-mortem histologic evaluation of this scar. You can see here that this scar is exactly similar to that we find usually in arrhythmogenic ventricular cardiomyopathy. It's a fibrofatty scar confined to the epicardial layer of the left ventricle. In other words, it's very similar in terms of wavefront of the lesion that, like arrhythmogenic ventricular cardiomyopathy, progresses from the epicardium to the endocardium. And so this is a close-up of the histologic lesion, the histologic scar, that shows that we deal with the fibrofatty scar, very similar to that found in arrhythmogenic ventricular cardiomyopathy. Most importantly, it's not the yield myocarditis, it's a cardiomyopathy. We found a digenic desmosomal mutation in this patient. So this is a very important concept. When we define myocarditis, when we say this MRI pattern is consistent with myocarditis, we usually suggest, we think that it's consistent with the yield viral myocarditis. Instead, myocarditis means myocardial inflammation. Myocardial inflammation is not exclusively of course, viral inflammation. You can have inflammation, autoimmune inflammation, and most importantly, most often, the myocardial lesions induced by genetically determined cardiomyopathy are myocarditis mediated. This is very important. In other words, we usually can find the same lesion, the same pattern of the lesion in different setting of a myocarditis. Also, sarcoidosis is a myocarditis, a chronic myocarditis. It shows the same ECG pattern, an epicardial scar in the left ventricle. So in other words, we think that is a final pathway of myocardial lesions that are probably induced or mediated by a myocardial inflammation, but most often may be, or significantly, more often may be related to a genetic myocardial disorder and are not so benign because they can induce ventricular fibrillation and sudden death. We also extended our examination to the other family members. We performed a cascade family screening, and you can see also the brother, that is also a cyclist, shows the same lesion in the same location of the left ventricle, and while the other member is apparently negative. But we showed a single desmosomal mutation in both. So it's a familiar and genetically proven cardiovascular disease. So in conclusion, with regard to this second time of potentially lethal left ventricular scar, we can say that in athletes presenting with ventricular arrhythmias with the right bundle branch morphology, suggesting for a left ventricular origin, a normal echocardiogram doesn't exclude the presence of an underlying potential lethal arrhythmogenic substrate. This is an important concept. It's not enough, the echo. So left ventricular lateral linear enhancement on contrast-enhanced cardiac MRI should not be dismissed as a benign sign of ill myocarditis because it may represent a marker of a heart muscle disease at risk of sudden cardiac death during sports. Thank you for your attention.